board certified board certified by the American Board of Dermatology and the American Board of Pathology. She is passionate about resident and medical student education, as well as mentorship within dermatology and dermatopathology. She also is the director of dermatopathology resident education. Dr. Gottesman's clinical and research interests include general and complex medical dermatology, inpatient dermatology, caring for patients with sarcoidosis, granuloma annulare, and other granulomatous diseases. She's extremely interested in special needs dermatology and strives for inclusive clinical experience and frequently takes care of children and adults on the autism spectrum with various dermatologic conditions. Dr. Gottesman completed her internal medicine internship and dermatology residency at the University of Arizona, where she served as chief resident in her senior year. She then completed a dermatopathology fellowship at the Ackerman Academy of Dermatopathology in New York City in collaboration with SUNY Downstate Medical Center. Dr. Gottesman is also the founder of an international online dermatopathology journal club, DermPath JC. She's a member of several professional societies, including the American Society of Dermatopathology and the New York Pathological Society, where she holds committee positions. Dr. Gottesman also serves as a reviewer for multiple prominent dermatopathology journals. She's also published numerous articles in peer-reviewed literature, authored several book chapters, as well as given talks at local, regional, and national dermatology and pathology conferences. She's involved in a host of community wellness initiatives via community education about skin cancer incidents, sunscreen safety practices, and providing community skin cancer screenings. So without further ado, Dr. Gottesman.
Thank you, Bessie, so very much for that very warm and kind introduction. So today we're going to talk about a subject that is very near and dear to my heart, and it's called lichenoid and granulomatous dermatitis. So before we, dive in to the topic, I think it's really important to set the stage, to set the backbone for this talk. And I'm going to use this book cover as an example. This is the histologic diagnosis of inflammatory skin disease by Dr. Bernard Ackerman. By many, he is, thought to be the father of dermatopathology. That's not to say that dermatopathology did not exist before Dr. Ackerman entered the playing field. However, he was a very prolific writer, numerous books, numerous book chapters, numerous articles, and one of the most prominent one was this one. I think he really helped put together this amazing, A to Z organization of all the different skin inflammatory diseases by pattern, so that he could help trainees, not just in dermatology, but also in pathology, to create a differential diagnosis based on the pathologic findings that they're seeing. And oftentimes, if it's a unique inflammatory pattern, actually be able to walk out with a diagnosis from examination of that slide. So this is not an exhaustive list, but I thought it would be a great idea to just kind of touch base on these different inflammatory patterns. My dermatopathology fellowship mentors, Dr. Gottlieb and Dr. Hellman, always said, low power exam equals high power mind. That means a lot of our residents, when they're looking at slides, they immediately go to the high power and then they get lost in the minutia. And I think the most important thing when you are looking at a slide of an inflammatory dermatosis, because most of those will be punch biopsy specimens, is on low power, take a look at where the pathology is. Is it in the epidermis? Is it in the dermis? Or is it in the subcutis? We're not going to use the subcutis here as an example at all, because the panniculitis could be a 2-3 hour webinar at least. So we're going to talk a little bit about the spongiotic psoriasiform, the acantholytic pattern. Those are epidermal patterns. We're going to talk about the interface pattern, which are changes at the dermoepidermal junction, or the border between the epidermis on top and the dermis on the bottom. The lichenoid pattern, which is in the superficial dermis. The granulomatous pattern, which could be diffuse in the dermis, perivascular, perifollicular, perineural, and then the vascular pattern. So I thought it's best to, show some examples of these, starting with the spongiotic pattern, right? This is an epidermal pattern. And I often tell the residents this is a wet dermatitis. So what does that mean? You have spongiosis or edema intercellular between the keratinocytes. And because of that edema, you're able to see the little desmosomes between the individual keratinocytes. You have serum crusting, which you can see it on top of the epidermis or in epidermal spongiotic vesicles. So why is it a wet dermatitis? If you are brave enough when you're examining this patient in the office and you're not wearing gloves and you touch their skin, it will be wet because what you're touching is the serum. So if you look at this slide here on the left, right, a low power view, this is a high power view. And then we're looking at the slide and we're deciding where is the change? The change is predominantly within the epidermis. Okay, so it's an epidermal pattern. Contrasting that to a psoriasiform dermatitis. A psoriasiform dermatitis, it's also an epidermal change, right? The most characteristic findings are in the cornified layer. You have neutrophils there, you have parakeratosis, but it's a dry dermatitis. There's no crusting. Below it, you'll have a loss of granular layer and you'll have this epithelial hyperplasia and many, many other characteristics of psoriasis, right? Thinning of the suprapapillary plate, dilated capillary loops, et cetera, but this is a dry dermatitis. And usually when it gets processed in sections, this scale tends to fly off. These patients will have these white micaceous type scale on the, say, elbows and knees, most common psoriasis presentation pattern. And when you touch these patients in the clinic, it'll be dry. You're not going to get any serum crusting transferred onto your fingers. The acantholytic pattern is different than the spongiotic pattern, okay? Here we have loss of the desmosomal connections between the keratinocytes, and they look very round and they're free. They almost look like they're free floating during processing sections. So acantholytic dermatitis, can have a positive or negative direct immunofluorescence based on the different clinical presentations. So we're not going to talk about that more than that. So the interface dermatitis is a dermatitis. It's the connective tissue pattern dermatitis, right? We have changes at the dermal epidermal junction. So the changes of the dermal epidermal junction are marked by a vacuolar change. What does that mean? There's lymphocytes at the dermal epidermal junction. They don't grow keratinocytes, so they'll have their little vacuoles around them. They don't grow their desmosomal connections like the keratinocytes. And because of their close proximity to the basal keratinocytes, some of them will be injured on that battlefield, and you're going to have these dyskeratotic keratinocytes that have very pink cytoplasm, and they'll have shriveled nuclei. So then you have that interface pattern, and then you'll look for other things. The lupus pattern is an interface dermatitis, superficial and deep, perivascular and periadnexal lymphocytic infiltrate in the absence of eosinophils. The vascular pattern, for example, we're going to use leukocytoclastic vasculitis. Here you have different type of inflammatory cells. You have acute inflammatory cells or neutrophils. Some of them are intact. A lot of them are fragmented. That's called leukocytoclasia or karyorrhexis. The vessels are leaky. They're injured. You have extravasation of red blood cells. These anucleate cells here are red blood cells. And then over time, you have fibrin deposition. So those are like basic inflammatory patterns, and all of those correspond to a chapter in, our dermatopathology textbooks, depending on, which one your institution is using. Today, we're going to focus on lichenoid and granulomatous patterns. First of all, we're going to use lichen planus as an example. Lichen planus is an interface and lichenoid dermatitis. A lot of residents get confused by that because they think of, oh, interface dermatitis is lupus, dermatomyositis. What is lichen planus doing here? If we really look closely, you will notice that there is an interface change at the dermoepidermal junction. But if it's easier for the trainees just dipping their toes into dermatopathology to just think of lichenoid dermatitis as its own class of disorders with this lichenoid band of inflammation, that's quite all right. So here's an example of lichen planus here on the left. And here we have granulomatous dermatitis. In granulomatous dermatitis, you have predominantly histiocytic infiltrate. The histiocytes come together to make giant cells. Sometimes the inflammatory cell infiltrate that is accompanying these well-formed granulomas could be paucicellular lymphocytic. Sometimes it could be very inflammatory with lots of chronic inflammatory cells, so lymphocytes and plasma cells. Sometimes necrosis and even frank abscesses, so localized collections of neutrophils. But what happens if you're looking at an inflammatory biopsy and sometimes you just have more than one pattern? So here's pearl number one. You have to keep an open mind. And when you look in a biopsy with a combined inflammatory pattern, you can't put it into one particular chapter from your dermatopathology textbook. So we are going to talk about lichenoid and granulomatous dermatitis, but biopsies that are showing this combined inflammatory pattern at the same time in the same specimen. We're going to refer to a lot of papers from the literature. The most recent one talking about lichenoid and granulomatous dermatitis is Braswell's group, which was published in the JAD in 2019. And I'm just going to use this picture as an example of what they were seeing clinically, a papulosquamous eruption. Why do we say that? So we have small erythematous papules, and they have a scale. So these are palpable. There's a scale. They're coalescing together to make plaques. In the dermis, in the epidermis, you're going to see changes in the cornified layer, parakeratosis plus minus neutrophils, which really correspond to the scaling that you're seeing clinically. And in the dermis, you're going to see a band of inflammatory cells, lymphocytes, and then well-formed granulomas with giant cells. This is one of their patients that had a lichenoid and granulomatous drug eruption. But before I show you more examples from my own sign-outs, I think it's really important to talk about a little bit about the immunology of lichenoid dermatitis and granulomatous dermatitis. So the lichenoid pattern, we're going to use lichen planus as our example. It's characterized by a band-like infiltrate of lymphocytes in the papillary dermis, and they're abutting the epidermis. And because of their presence there, as we saw earlier, there are some changes at the dermoepidermal junction. So there will be interface changes. But within that band of lymphocytes, the lymphocytes are not the only actors present. There are a lot of macrophages, which may not be readily visible to trainees in their earlier years until they see a lichen planus of a darker skinned patient and they see a lot of melanized histiocytes. Those are called melanophages. And we also have some plasmacytoid dendritic cells, which are responsible for interferon alpha production. So as of now, what we understand, lichen planus is, it's some kind of T-cell mediated inflammatory disorder. And every time I have a patient with lichen planus in clinic and they ask me, oh, what caused this? And unfortunately, my answer a lot of times is we don't know. Perhaps some kind of virus, perhaps hepatitis C. It is 5 times more common in patients with lichen planus. We test for that, but 99% of the times I send for that, it's negative. Perhaps certain medications, but those patients will label with a lichenoid drug eruption rather than drug-induced lichen planus. Perhaps certain contact allergens. There are some patients with limited oral lichen planus, and they develop it as a result of certain metal fillings. But a lot of times, we don't know what's causing this lichenoid pattern. We try to do immunohistochemical stains to stain what kind of lymphocytes are present there. So we know there's increased number of cytotoxic CD8 positive T lymphocytes, and these are the ones that are probably responsible for the basal layer keratinocyte injury. Not only we don't see only dyskeratotic keratinocytes, over time we also see SAVAT bodies in the superficial papillary dermis, which are basal layer keratinocytes remnants. They're often covered by IgM, sometimes even IgA. But as we have a lot more colleagues in our immunobiology field interested in lichen planus, we learn more about it, that perhaps there's some Th1 and Th17 lymphocytes that play a part as well, and they end result of secreting key inflammatory cytokines like IL-17 and interferon gamma that propagate the process further. So the granulomatous pattern, we're going to use sarcoidosis as an example, because often in lichenoid and granulomatous dermatitis, the type of granulomas that we see are the epithelial type of granulomas. So in sarcoidosis, there's some kind of infectious or environmental trigger, usually in a genetically susceptible host. And here we have CD4 positive T cells, which secrete high levels of interferon gamma and other inflammatory cytokines such as IL-2 and IL-17. We have macrophages that in turn produce additional cytokines, including TNF-alpha, which leads to development of granulomas. And then they create this self-sustaining loop of perpetual granuloma formation, and the process keeps going and going. So, so what happens in lichenoid and granulomatous dermatitis? Perhaps there's, sort of like a marriage of both of these halves of the slide. So I think we're starting to recognize this pattern more and more, and perhaps we'll know a lot more in the future. So lichenoid and granulomatous dermatitis has been around for quite a long time. The very first case report was published in 1986 by Dr. Gonzalez. And I did not include his photomicrograph, but it looks identical as the patient that I'm going to show you from my clinic. He presented a 52-year-old female with a generalized papulosquamous eruption, and they thought it was secondary to an antihypertensive medication. There were two different medications that were new, both antihypertensive, so they thought it was one of those for sure. But the literature didn't see too much of lichenoid and granulomatous dermatitis until the early 2000s, when the largest case series up to that point was published by Dr. Magro and Dr. Krausen and included 40 different patients. And the age range of their patients was pediatric, age 5, all the way up to 86. Females were slightly more represented than males. Their distribution was variable, but included trunk extremities, some patients with head and neck involvement, and 15% of them had a generalized eruption. Then fast forward almost another 2 decades, we see the largest case series that we have to date, 56 patients from the Braswell group, and the age range is similar. We have from the teens, 13 to 93. Their males to female ratio was equal, and they too reported grouped lesions. They reported solitary lesions, they reported annular smooth papules, they reported scaly papules, they reported generalized eruptions. So the clinical presentation can be very variable. And it makes sense that you'll never see on the requisition a dermatology clinician saying rule out lichenoid and granulomatous dermatitis, because more often than not, when you have a patient with a papulosquamous eruption, you're going to think about psoriasis, you're going to think about pityriasis rosea, you're going to think about pityriasis lichenoides chronica, you're going to think about drug eruption. But you're looking at a slide of a lichenoid and granulomatous dermatitis, and you're trying to put it into a box of an inflammatory pattern, and you just simply can't, because they're two different components. One component is the lymphocytic component, the lichenoid component, and you have something that looks like lichen planus, but it's completely disrupted because within that band of lymphocytes, you also have a lot of histiocytes. And these are the different patterns both of the case series reported. So they reported loose histiocytic aggregates kind of interspersed within that lichenoid band of lymphocytes. They reported epithelioid granulomas within that band of lymphocytes and below it within the dermis. They reported singly disposed giant cells, perineural and perifollicular distribution. So pearl number 2 is not every pathology report that you receive will have your patient's diagnosis. So a pathology report that says lichenoid and granulomatous dermatitis, C comment, is actually just a descriptive diagnosis of an inflammatory pattern. And usually in that comment, the dermatopathologist will talk about the initial workup they had done on the specimen, will offer a differential diagnosis, and then perhaps, if they're comfortable, offer additional clinical things that could be performed that the clinician will have to order and follow up on. So it's really important to be very thorough and to do the detective work, because, as I said, a diagnosis of lichenoid and granulomatous dermatitis is just an recognition of an inflammatory pattern. Oops. So I'm going to use an example from my clinic. And I was very fortunate to meet this patient first as a pathologist and then as a dermatologist. So this was a 68-year-old male who presented with crops of group smooth. They were very, very smooth. I would say 3/4 of them very smooth, very annular dermal papules. Some had a little bit of scale. They were present on the upper arms. This is the antecubital fossa here. So kind of the upper inner arms and then the upper shoulders and upper back. They were asymptomatic, but they were increasing in size and number. And the patient was feeling anxious. He came to a dermatologist, one of my colleagues, who biopsied him for H&E and for tissue culture. And I got to look at those slides. So here we have his biopsy. And as we are seeing, there are two things going on. We have a lichenoid band of lymphocytes. There are brisk, and they are involving the dermoepidermal junction. There are some diskeratotic keratinocytes, and there are some Sivat bodies present in the papillary dermis. But what's disrupting this lichenoid band of inflammation are these very well-formed granulomas. So in some of them, you just have histiocytes coming together, and in this one, you even have a giant cell. So what we're looking at here is a combined inflammatory pattern. So I can just say lichenoid and granulomatous dermatitis. Okay, next case, right? But I really haven't helped my colleague at all, because all I have done is describe the pattern of inflammation that I see. I have another zoomed in photo. It's a little bit fuzzy, but you are able to see the granulomas here, some histiocytes here. And then here, I just wanted to focus your attention to these Sivat bodies. So here's another example. Deeper sections are your friend. So you'll do more deeper sections, and you keep encountering the same pattern. You know, in this section here, we were lucky, and we were able to even see some interface change in some Sivat bodies. In this section from the same patients, we're not seeing, you know, deepers into the block. We're not seeing interface involvement, but we still have that lichenoid band of inflammation of lymphocytes. There are some histiocytes here, but coming together really nicely in this well-formed granuloma. So some of the workup that I had performed on this patient's biopsy was doing special stains for microorganisms. So PAS for fungi, which was negative, AFB and FIDE for acid-fast microorganisms, TB, and M. leprae, which were negative, and Gram for bacteria. I did an immunohistochemical stain for syphilis, which was also negative. These were some additional labs that were done after my signed out report, and these were also negative. So syphilis and TB and HIV tests were all negative. However, the patient's rash was progressing, and he returned several months later, 3 to 4 months later, with more lesions, with larger lesions, and now he had positive review of systems with some myalgias and arthralgias. So what did we do again? The patient got another biopsy, and this biopsy looks different, doesn't it? You are not seeing the very well-formed lichenoid band of inflammation. You're just now seeing the extremely numerous and extremely well-formed granulomas, epithelioid granulomas in the superficial dermis. And now more comfortably, you can say, wow, gee, I think this patient has sarcoidosis, which leads us to pearl number 3. And pearl number 3 is called Lives of Lesions. And that comes from my training in fellowship, but also that was inspired into this book, Lives of Lesions, or Chronology in Dermatopathology. So it is a beautiful book. If you can access it in a library or find it on eBay, I highly recommend it because there are examples of very early lesions, of very late lesions, inflammatory lesions, and how difficult it is to diagnose something from the pattern that you're seeing at that point in time. And then the peak changes in the peak lesions that we put in the textbooks to teach you and to then test you on the boards. And kind of like a sub-pearl to pearl number 3 is you can always re-biopsy the patient. The rash is progressing, not responding to treatment, biopsy it again, because the second biopsy can yield additional information. So that's one example of lichenoid and granulomatous dermatitis. Another example is a 58-year-old female. Presents with an eruption on the lower extremities. Initially notes that the lesions were more red, but now they're turning more brown in color. These lesions were asymptomatic. She was feeling well. There were no new medications. This specimen was sent to me by a community dermatologist who was not using the hospital EMR. So I didn't have the privilege of immediately looking at the patient's photos. So whenever I have an inflammatory biopsy, I think it's really important to remove all bias as much as possible. And the requisition form that you're getting from the clinician, in a way, it's some kind of bias. It's what their clinical impression is from the eruption. So when I was trained in fellowship, we were always taught, look at the slide blindly, because it tells you a story before you bias yourself with the gender of the patient, age of the patient, distribution of the lesions, and the clinical impression of the dermatologist. So look at that, put it into a box. You know, what kind of inflammatory pattern do you see? Is it a solitary inflammatory pattern? Is it a combined inflammatory pattern? Then help yourself by looking at additional information. And then for me, usually first line includes looking at information from the requisition form. Then my second tier of, digging is digging through the chart if I have access to the chart. And then last but not least is clinical photos. So I think histiocytes are one of the hardest types of cells to photograph, but I'm going to guide you through this biopsy. And some of the things might not be very obvious at first. So we have a band of lymphocytes in the superficial dermis, right? Because this is diffuse cells, briskly inflamed. And I can draw a line here and I can say there's a band of inflammatory cells. So these small dark blue cells that are usually the size of a red blood cell, and they have no cytoplasm, those are all of your lymphocytes. But interspersed between them, you have these larger cells that have this abundant eosinophilic cytoplasm. All of these are histiocytes. So if we were to do a CD68 stain, it would highlight so many of them. Besides those two different cells, you have some melanophages here, so some histiocytes that are taking up, well, it's not melanin, so I'm not going to call them melanophages. Maybe I should call them siderophages because this is hemosiderin. And then we have some extravasated erythrocytes. But still, this is a lichenoid and granulomatous pattern because we have these histiocytes. And in the case series by Magro and by Braswell, they both reported patients that presented with this kind of pattern, more kind of those diffuse, like singly disposed histiocytes, kind of disrupting this band of lymphocytic inflammation. So, I did what I always do, which is, the special stains is this immunohistochemical stain. And of course, it was negative. Additional labs that were done syphilis was checked again. Reason why? T. pallidum sensitivity, IHC, is only 71%. So you're not going to catch all syphilis cases. And we sure have a lot of it in New York. We see it quite frequently. And then quantiferin TB, some of these lichenoid and granulomatous dermatitis, they can be tuberculous. That means the organism is not in the skin, but the patient may have positive quantiferin. But this was negative, and the patient had no new medications and no other risk factors. So what do you do next? This goes back to pearl number 2. Be curious, do the detective work, do the clinical pathologic correlation. And the best way to do that is by getting on the phone and talking to the clinician and asking them, hey, what do you think is going on with this patient? This is the inflammatory pattern that I'm seeing. We did these tests, they're negative. You did these tests, they're negative. Can I take a look at the clinical photo? And then this is her clinical photo. So we came to a diagnosis of Schomburg's disease. However, Schomburg's disease is not typically granulomatous. So there is a subtype of pigmented purpuric dermatitis that is granulomatous. And the patient did say that her clinical presentation looked more like this early on. And now it started to look more dark, probably because of more hemosiderin deposition over time. A pearl Prussian blue stain could be used to prove the presence of hemosiderin. And it was an asymptomatic eruption, remains asymptomatic with some improvement now over time. So more examples. These are published images on the Pathology Outlines website, but I have contributed them. So this is an example of syphilis. Usually, when we teach syphilis, we teach the residents there's a psoriasiform, pattern. That means there is epidermal hyperplasia, which can be even. Often you'll have perikeratosis and neutrophils on top, and you'll think psoriasiform. But differing from psoriasis, you have an interface pattern, and then you have a lymphohistiocytic inflammation in the superficial dermis with a lot of plasma cells. Well, if you have a classic syphilis like this, this is a patient on top in his mid-50s with a papillosquamous eruption. You have a classic syphilis here of a patient in his mid-20s presenting with a papillosquamous eruption. You look at this, and you're not going to think about a lichenoid and granulomatous dermatitis. You're going to think, oh, this looks like syphilis. I'm going to do my T. pallidum immunohistochemical stain, and I'm going to highlight all of my little spirochetes that are present there. Great, next case. However, syphilis has many faces, and sometimes it can be a lot more granulomatous. This is another example of how difficult it is to photograph histiocytes, because I think that contrast is so hard to get from the background dermis. But you can see that the tiny blue cells that are here in a band-like distribution, they're lymphocytes, and then these lighter grayish purple cells here. All of those are histiocytes. So you can say this is lichenoid and granulomatous dermatitis if it doesn't immediately scream syphilis to you when you're looking at it. So this is a T. pallidum, a lot less number of spirochetes here from Dr. Moudaliar from Loyola. And I think this is an even better example of a lichenoid and granulomatous dermatitis from Dr. Hitt, which is syphilis. So if you're looking at this, I can draw a line here, and there's brisk lymphocytic infiltrate, but the granulomatous component is a lot more pronounced. So, so I think the two different case series of lichenoid granulomatous dermatitis that we have that are the largest ones, right? 40 patients from Dr. Magro and 56 patients from Dr. Braswell. They both agree that the number one cause for lichenoid and granulomatous dermatitis is medications. So drugs, drugs, drugs. And these are the different medications that were described. So ACE inhibitors, angiotensin receptor blockers, antibiotics, certain antibiotics, lipid-lowering agents, antihypertensive medications like beta blockers, calcium channel blockers, and hydrochlorothiazide, antihistamines, proton pump inhibitors, NSAIDs, Plaquenil, TNF-alpha inhibitors, serotonin selective reuptake inhibitors, some diabetic hypoglycemic medications, and recently even 2 cases of patients on dupilumab for atopic dermatitis clearing their atopic dermatitis and subsequently presenting with a lichenoid and granulomatous dermatitis pattern that look identical as some of the slides that I showed you. It's listed in the references if you're interested about it. What's different in the Braswell group, that a lot of times they did have a solitary lesion, and that usually came in as rule out a basal cell or rule out a seborrheic keratosis. But what the slide showed was a lichen planus-like keratosis, and there was granulomatous inflammation. And now if I think, looking back, I had never been stumped by an LPLK with a little bit of granulomas, because I look at the history and I see, they only want a solitary lesion. And I think it happens more often than not to have a little bit of granulomatous inflammation in LPLK. So I'm really glad to see that represented in Braswell's group. I think the Magros group described more of an infectious trigger, and maybe it just differs the types of patients that they have in their respective communities. The microorganisms that were described found in lichenoid and granulomatous dermatitis were M. leprae, M. marinum, M. tuberculosis, and as I mentioned previously, so as a true infection in the skin or as a tuberculate, where the special stain in the skin will be negative, but the quantiferon TB will be positive, or the patient will have, other tuberculosis involvement of other organs, tinea capitis, hepatitis C, id reactions to EBV, and herpes zoster granulomatous dermatitis. In patients where a cause, wasn't found from the ones that I mentioned, it was noted that they had an underlying medical condition like rheumatoid arthritis, Crohn's disease, hepatobiliary disease. Tattoo reaction can give you a granulomatous dermatitis. Tattoo reaction can give you a lichenoid and granulomatous dermatitis. And guess what? Patients with sarcoidosis will often have sarcoidal granulomas in their tattoos. So it does not exclude sarcoidosis. And as we saw earlier, an example of lichenoid and granulomatous dermatitis that with time manifested as sarcoidosis. So the take-home points, if they're eosinophils in your lichenoid and granulomatous dermatitis, you can search for a medication, and it will be a drug-induced lichenoid and granulomatous dermatitis. And this was statistically significant. This was also a statistically significant change in the Braswell series. They saw psoriasiform, which means even epithelial hyperplasia with interface change. So the interface change showed dyskeratosis of keratinocytes, and below it there was a lichenoid band of inflammation with well-formed granulomas and eosinophils. Sometimes this hyperplasia was so pronounced that it even had appearance of a pseudoepitheliomatous hyperplasia, and usually the culprit was a drug. If there's tattoo pigment, think about a tattoo lichenoid and granulomatous dermatitis, and of course keep sarcoidosis in your mind. If there are plasma cells, if you're lucky, right, 2/3 of syphilis cases will have plasma cells, a third of them will not. So if you have lichenoid granulomatous dermatitis with plasma cells, you can think about syphilis. The Braswell group did mention quite a few granulomatous pigmented purpuric dermatitis patients presenting with a lichenoid and granulomatous pattern that also had some extravasated erythrocytes. So if you see that in your biopsy and it is the right clinical setting, you can think about PPD. And if there is lymphoid atypia, then you have to worry about an unusual subtype of CTCL, which would lead to additional immunohistochemical workup, T-cell gene rearrangement, and other things. I think both of the case series were excellent because they collectively put together almost 100 patients, while the Magros group saw more of an infectious trigger, some CTCL patients that the Braswell group did not see. Both of them agree that the number one culprit for lichenoid and granulomatous dermatitis is probably a medication. So So I think now when you have a lichenoid and granulomatous dermatitis as an inflammatory pattern in your biopsy, you can think of, oh, wow, okay, this is a combined inflammatory pattern. These are some things that we could do, some special stains, some labs that we could do to exclude the possibility of infection. However, most of the time, it will probably be a medication-induced reaction. So it's really important to go back to the patient and to do a drug chart to see what medication was most recently started or changed that could be responsible for this. And then whatever the trigger is, you're treating that underlying condition. These are my references, and they're very, very good. Either case report, the two big case series that we talked about. So if you need additional reading, I highly, highly recommend them. And that's all I have for you today. I'm glad I stayed on time.
Thanks. That was really fantastic. So clearly presented, great pictures. Just really informational and great. We do have some questions. The first one is more sort of logistical, as will there be recording? Yes, we'll have this session, or the session is recorded, and we'll post it online on our YouTube channel, Global Dermatology Talks. So I have a question. There's this sort of nomenclature about reactive granulomatous dermatitis, interstitial granulomatous drug reaction, other things that fall under that umbrella. I think it creates a lot of confusion, and I'm sort of just wondering how you think about this. Is sort of lichenoid and granulomatous drug reaction sort of a subset of that, or is it distinct? And I'm just kind of curious your general impression.
Yeah, I'm glad you mentioned that, because I think it's like an alphabet soup when you're teaching the residents about PNGD, IGD, right? And drug-induced IGD. And all of those different patterns, they described something separate from the lichenoid and granulomatous dermatitis, but I would put them all in the same category. This would be like the fourth category. In palisading neutrophilic interstitial granulomatous dermatitis, you have a lot of neutrophils, you have a lot of, you can see vasculitis. In interstitial granulomatous dermatitis, it's very clean, lots of histiocytes, right, wrapping around those collagen bundles, giving you that appearance of floating collagen bundles, which could be drug induced if you have eosinophil. So a drug-induced interstitial granulomatous dermatitis is different from Magros described interstitial granulomatous drug reaction, which will also have the interface change that in drug-induced interstitial granulomatous dermatitis you're not going to see. And in interstitial granulomatous drug reaction, you'll also have some kind of lymphoid atypia and tissue eosinophilia. So you have those three categories. And now we have a fourth one, lichenoid and granulomatous dermatitis. And I think what Dr. English and Dr. Rosenbach tried to do is aptly so say these are reacting to something. This is an inflammatory pattern. It's a granulomatous pattern. It's reactive to something, whether it's to an infection or medication or underlying autoimmune process. You know, you can treat the dermatitis that you see clinically with some topical steroids or oral steroids or other immunosuppressive agents, but a lot of times you have to treat the underlying condition that's causing it. So I think this would be a great fourth category to put up there into maybe a follow-up paper for Dr. English and Dr. Rosenbach. Reactive granulomatous dermatitis revisioned.
No, that's great. Thank you for that. So I guess kind of related to that, so we think about drugs and other underlying causes. Have you ever seen cases of lichenoid granulomatous dermatitis that you feel like are primary? Like, is this just can it be a very unusual primary reaction pattern?
I can't say that I have. I guess in lichen planus like keratosis with a little bit of granulomas, that could be like a primary lichenoid and granulomatous dermatitis, and it's just a solitary lesion. You biopsy it, and the lesion resolves, and the patient doesn't develop other. And I wonder why that LPLK has granuloma formation. Perhaps there's some kind of environmental trigger locally from the patient doing something to that spot, because a lot of times the patients will come with lesions that are manipulated. So I haven't seen a primary lichenoid and granulomatous dermatitis, to answer your question.
Thanks. Yeah, no, I have another. I was just kind of curious your thought. Because you know so much about it. We have another talk from the audience. It's an anonymous attendee. Says, great talk. Thank you. Would different patterns have different treatment plans / responses within the same diagnosis?
Yes. If you have a patient with syphilis, you're going to treat them with penicillin, penicillin, penicillin. And if they have an allergy to them and they're pregnant, you're going to desensitize them with an allergist and still treat them with penicillin. If you have a patient with a drug eruption, hopefully removing the medication will clear the eruption, but in the meantime, you will support them with other medications like topical steroids, oral steroids, sometimes even a little bit of Cellcept. I'll throw Cellcept on anything. If you have a patient with, let's see, infection, we talk about you treating the infection, medications, removing the medication. If the patient actually ends up with a diagnosis with a mycophenolate with a mycosis fungoides, then it's a completely different ball game. So you treat the underlying condition, and then you also support the skin.
That's great. Thank you. Another question is, do we understand the immunology underlying hepatobiliary reactions?
I don't think I do. From my limited experience, I haven't had a patient with an underlying hepatobiliary disease presenting with this kind of eruption. So if somebody does, I'm happy to learn more about it.
That's great. Thank you. The one last sort of scientific question I wanted to ask about is, so now there's this talk about rubella-associated granulomas, and I'm still personally trying to kind of wrap my head around when to think about that. Have you seen cases, or have any of them, if you have, had sort of a lichenoid and granulomatous pattern?
You know what? We haven't been fortunate to see those here, but we did have a grand round speaker, Dr. Vanat, who is amazing, brilliant, and she's the one that's most published on this condition. So I'm excited to continue to follow her discovery to see if some of the patterns intertwine, and if that will, get a slide in a future lecture with lichenoid and granulomatous dermatitis. We haven't seen any on Long Island.
Great, thanks. And we've got about 4 minutes left. Often we have a lot of trainees in the audience. To the extent that you're comfortable talking about it, would you mind talking about your sort of path to dermatopathology and any
Sure.
real
I matched into dermatology residency with very limited pathology experience, except for the histology in the first year of medical school. And I would say pathology, it's really important when you're studying to become a dermatologist. 25% of the questions on the dermatology boards will be dermatopathology themed. So it's really, it was really exciting for me to learn that in my first year of dermatology residency. And the way I was exposed to it was a dermatopathology power session, a weekend session by Dr. Jared Gardner, and it was held in Phoenix, and it was specifically geared for our senior dermatology residents to prepare them for the dermatopathology portion of their boards. And I was just so amazed by the different patterns that bravely, on day 2, I would start to say what I see on the slide and get it right. And I think it's really important to have somebody to encourage you and you to follow their encouragement. Dr. Gardner had said that you look like you have an eye for dermatopathology. Dermatopathology is a huge part of dermatology, and you should definitely pursue that if you can. And I thought, wow, I had never really known that. So if you have a mentor, even just an accidental mentor that notices something about you that you are passionate about, but you don't even realize it, or that you may have a knack for it, I think it's worth further exploring it. So I just asked for additional dermatopathology, selectives or electives during my dermatology training. And I was glad to have that experience early on, because the dermatopathology fellowship, applications are due very, very early at the beginning of your PGY3 year, which is the beginning of your second year of dermatology residency. So I think the exposure that as trainees you have to dermatopathology on Twitter or other social media, I think it's really important, if you find some love in it, to further explore it, either through a dermatopathology fellowship right after a dermatology residency, or even later on. When I was at the Ackerman Academy, they were dermatologists that were already in practice, and they wanted to come back and do additional training and applying for a dermatopathology fellowship. So it's never too late to shape your career to what the present interests are at the time.
Thanks. Great note to close on. Thank you for sharing that. From everyone, thank you for your time, your expertise, and such a clear and educational presentation.
Thank you so much for the invitation. I really appreciate it, and happy upcoming holidays to everyone.
Thanks. Take care.